Good morning. It's nearly good afternoon. Carry on with the differential diagnosis. Again, my title was given as the overriding aorta, and I think we'll develop a little bit more as we go along, but I thought it was important, like Lindsay, to define right at the beginning what we mean by overriding and the vessel. And I know there are a lot of people here from different countries where the language, like mine, is not also English as the primary language. So I went very cleverly to what most people use now, Wikipedia, and typed overriding aorta. And to my surprise, it actually has overriding aorta there. And it's defined as a congenital heart defect, and the underlined words are mine, where the aorta is positioned directly over a ventricular septal defect. So I think that becomes reasonably clear if you know about the heart, you know what ventricular septal defect is. And I look a little bit further, going through a dictionary to see, well, what does override means? It might not be very clear. And actually, words that mean more or less the same may become more clear for some people. It's overlap, or if it's traveling or moving over, so it's kind of a position displacement of the vessel. Now, I didn't cross the tie to overriding aorta, but I have modified it throughout the talk because it is a differential diagnosis. We have two ventricles, we have a ventricular septal defect, and we have a vessel. And I think the first thing in the differential diagnosis of an overriding aorta, in inverted commas, is not to assume that this vessel is the aorta. Because you have to prove first that it is the aorta before we come to that differential diagnosis. I think that's very important. So I'm going to redefine, and we're now going to talk about not an overriding aorta, but we're going to talk about a vessel that is overriding. And a vessel overrides, usually there are two ventricles, so there is a biventricular connection from that vessel, where the valvar leaflets is kind of in between the two ventricles, overlapping the ventricular septum. Now we come back and then we start talking about what vessel can that be. And then we're back to our initial title. And the first differential diagnosis of the overriding vessel is that it is the aorta. But as I said, don't assume that when you first start seeing a vessel that is across the ventricular septum. The second possibility is that that vessel is actually the pulmonary artery. So you have to first identify which one is which. And the third one will be, it's neither of those, it is a common arterial trunk. So if we look further into the overriding vessel and back to the definition, that vessel is coming from two ventricles. And if we think in terms of the whole diagnosis, and here we're splitting the overriding aorta and trying to make a diagnosis, but in complex abnormality, and we'll see that later, it's important to see the various segments of the heart and put everything together. And if we're talking about overriding aorta, we're looking at the connection or overriding vessel, the connection of that ventricle, that vessel with the ventricles. And in sequential segmental analysis, which is our preferred terminology for complex abnormalities, a vessel is assigned to a ventricle to which it is connected to by at least 50%. So if we think of that, that vessel overriding can belong, in a way, more to one ventricle on the left or the ventricle on the right, and depending on to which it is more connected to, and on the presence or not of a second vessel, the ventricular arterial connection can be concordant. That's the normal. So that overriding vessel is probably the aorta and is connected to the left ventricle, and you have a pulmonary artery coming off the right ventricle. It can be discordant, which is in transposition. It can be the two vessels primarily from one ventricle, and it can just be one vessel overriding, which would then be a single outlet. So now we're going to come back to those three main vessels, the aorta, the pulmonary artery, and the common arterial trunk. And if we start with the aorta, the most common diagnosis when the vessel overriding the aorta is that of tetralogy of Fallot. So we have to start by demonstrating that the vessel overriding is the aorta. And secondly, that there is a second vessel, which would then be the pulmonary artery, which is seen to be connected to the right ventricle. So coming back to the connections, if that aorta overrides by less or up to 50%, the ventricular arterial connection is going to be concordant. But if the overriding is more prominent than that, and then it becomes a double outlet right ventricle in terms of the sequential analysis of the heart. Now, within this group of tetralogy, we still have subgroups, and it's important to get further details. Tetralogy is a whole spectrum of different types, different implications, different management in terms of timing and type of operation. The more common ones, tetralogy with pulmonary stenosis, but you can also have tetralogy of Fallot with pulmonary atresia and tetralogy of Fallot with absent pulmonary valve syndrome. So if we start with tetralogy and pulmonary stenosis, we have here a composite clip where we have the two ventricles, a large ventricular septal defect, a vessel overriding the septum, and really from here alone you wouldn't be able to say, well, this is an overriding aorta. It could well have been a trunk. So we need to demonstrate that this is the aorta, either by showing the arch from there or by showing a second vessel in a normal relationship. So if we play this clip, and you can see here that that vessel is receiving blood from the left and from the right ventricle via the large ventricular septal defect. So here we have, as we move up to the upper mediastinal, we're able to identify a second vessel which crosses over. So one overriding about 50% and a second vessel coming off the right ventricle, crossing over in a normal relationship that you have in concordant connections. So the features of tetralogy, on your three-vessel view, you'd have your superior vena cava, your aorta larger than the pulmonary artery, which is the opposite of normal. So we have a smaller than usual pulmonary artery, an aorta, and a superior vena cava. And you can see in this case, you can follow the arterial duct with forward flow from right ventricle through the main pulmonary artery and the duct, which is smaller than usual, coming into the descending aorta. So we have two vessels. We have from the start a ventricular septal defect with an overriding vessel. That vessel has the usual course of what we know to be the aorta, and there is a second vessel coming off the right ventricle with forward flow all the way along. So there is pulmonary stenosis, which is reflected by the smaller size of the pulmonary artery. So this is the classical tetralogy with pulmonary atresia, with pulmonary stenosis. So just in terms of size, it's quite nice in terms of follow-up of these babies to actually measure the diameter of the aortic valve and the diameter of the pulmonary valve. And you can see here, this is the opposite of what you see normal. Normally the pulmonary valve is just slightly bigger than the aortic valve. Second possibility, we do have an overriding vessel. We're still talking about tetralogy. So this vessel is going to be the aorta, but we have to demonstrate that it is the aorta. Two ventricles, large ventricular septal defect. It's called an outlet defect because it's very close to the outflow tracts. Quite a dilated vessel, flow from both ventricles. And as we play these, we'll see here, if you keep an eye on the right ventricle, there is a beginning of the outflow tract. The pulmonary valve moves a little bit, but we don't actually demonstrate forward flow across the pulmonary valve, although the pulmonary artery is there. And actually, what we do see here is that in the duct, we have reversal flow. So if we analyze this image in a bit more detail, it's always important when you start looking at the heart, and we come back to that on the sequential analysis, to establish right at the beginning of looking at heart which is the right and which is the left side of the baby. It will form the basis for you to get the diagnosis accurately in the most complex abnormalities. If you get that wrong from the start, you get lots of things wrong in terms of connection. So we would have established this is the right side, this is the left side. You can see the trachea here, the spine. This is kind of approaching our three-vessel view, SVC, aorta. And what we see here is that the aorta is to the right, so the right side aortic arch. But in this case, the arterial duct, which has reverse flow, is to the left of the trachea. So right side arch and left-sided duct with reverse flow. That flow goes all the way back into the pulmonary valve, which is atrial in this case, and then it bounces back and it falls forward into the branch pulmonary arteries, into the right and left lung. So this is tetralogy with pulmonary atresia overriding aorta. The vessels are crossing over, but we have reversal flow in the pulmonary, in the arterial duct without any forward flow across the main pulmonary artery. Tetralogy with absent pulmonary valve syndrome. This is much more rare, and paradoxically, the pulmonary arteries are quite different from the classical tetralogy with pulmonary stenosis or with pulmonary atresia, where the branch pulmonary arteries and also the main pulmonary artery in many cases are quite dilated. And these are quite often referred to as like a tumor or an aneurysm in the chest. You can see here, these are all still images, very dilated branch pulmonary arteries. And at the region of the pulmonary valve, you don't have a valve as such, they open and close, but rather a ridge which has an orifice. So it does allow blood to go through, but because it doesn't have a valve, it also allows regurgitation. So we have forward flow, which is usually with a degree of stenosis, and we have reverse flow. So we have that to and fro flow across the pulmonary outflow tract and the pulmonary arteries, which become progressively dilated and has much more implications in terms of prognosis and morbidity for the child, because this can, to some extent, compress the airways and cause additional problems from the respiratory side. And in fact, many of these students are very well from the heart point of view for some time, but they get lots of respiratory symptoms, or at least they can get. This is a very old clip of an absent pulmonary valve syndrome in tetralogy, where you can see it looks a little bit like a sort of butterfly wings here. These are dilated pulmonary arteries, and you can see flow goes into the pulmonary arteries, and it swirls around, and it comes back, and back into the ventricle. The right ventricle can become dilated, and in some cases, the baby can actually become hydropic in certain cases of absent pulmonary valve syndrome. So quite a wide group within tetralogy, and making the diagnosis of tetralogy is not enough. We need to try and specify how the flow is getting into the pulmonary artery. Is it forward flow? Is it reverse flow? Or do we have an absent pulmonary valve syndrome? Now, we're moving from the classical tetralogy, where you can see the pulmonary artery attached to the right ventricle, and we're still on the overriding vessel being the aorta. And this is a group with pulmonary atresia and ventricular septal defect. And there's a little bit of difficult terminology here, because for many people this is an end spectrum of tetralogy of Fallot with pulmonary atresia. So some people might refer to pulmonary atresia VSD, others might say tetralogy with pulmonary atresia. I'd rather call it pulmonary atresia with a VSD if I cannot see a connection on ultrasound between the pulmonary artery and the right ventricle. If I can make that connection and the valve is atretic, to me it is within the group of tetralogy with pulmonary atresia. So it's a little bit of difficult here with the terminology. But in essence, the overriding vessel is the aorta. You have to demonstrate that. And the pulmonary artery, you can't connect that to the right ventricle. So if you can't connect the pulmonary artery to the right ventricle, one, can you see the pulmonary artery at all? And two, how is the blood getting to the lungs? So those are things that will give you the differential diagnosis and further refinement on the diagnosis, because again, they will have different management implications. So we have pulmonary atresia with a ventricular septal defect, and in the best cases, you would have actually the central right and left pulmonary arteries there, even if they're not attached to the right ventricle, and they are supplied by the arterial duct. And in this case, usually the intrapulmonary vessels are well formed, and you're able to give a better prognosis, because quite often you can reconstruct a pulmonary artery at some point postnatally. The other group is when the pulmonary arteries are there, or sometimes they're not there at all. If they are, they're usually very small, and the way the blood gets to the lungs is via what we call MAPCAs, or major aorta to pulmonary collateral arteries. Now, if one doesn't see the pulmonary arteries, you have actually actively to try and define how is the blood getting to the lungs. Is it through the duct, or is it through the MAPCAs? Or very rarely you can have a combination of the two. You can have a duct and MAPCA in the same baby, but that's not usually the case. So if you think the overriding vessel, like here, is the aorta, because you can see an aortic arch, you then have to define, well, where is the pulmonary artery, where is it coming from, and how is the blood getting there? So in this case here, we can see on a transverse view the descending aorta just in front of the spine, and you can see on color flow some vessels arising from the descending aorta. It's usually around the level of the left atrium, so it's much below the aortic arch. This is a different patient. In a sagittal view, we can see a very large overriding vessel, which we would have shown on the scan that this is the aorta. You're not seeing any bifurcation here, overriding aorta. When we come to a transverse view, same baby, you see here a big aorta, and it's a minute pulmonary artery here, going to the right. Not really seeing a main pulmonary artery, not seeing any connection with the ventricle. And in these cases, you shouldn't just be satisfied that, is this a pulmonary artery? Where is the blood getting there? What do we do? How do we manage these babies? We then have to actively start looking for how the blood is getting there. And if you see here, color is very useful for that. This is power Doppler. And we see more or less at the level of the fourth chamber here, where you can see the two atria. That's the descending aorta, and you can see the collateral vessel. In this baby, in fact, had two collaterals. This one going to the right lung. It was quite a large vessel. You can see it here going into the lung parenchyma. And he had another one in a different level to the left lung. Now, I'm going to leave the pulmonary artery to the end. I'm going to move to the second vessel, being a common arterial trunk. So we have an overriding vessel, and we now cannot show that as being just the aorta. So the definition of the trunk is that it divides into the aorta, the pulmonary artery, and also the coronary arteries, which we obviously see more easily postnatally. We don't normally see those in the trunk prenatally. Now, within a common arterial trunk, we'll obviously have a ventricular arterial connection, which is a single outlet, because only one vessel that comes off and then divides afterwards. Most often, if you have a trunk, you would have, after it bifurcates, a normal aorta. But there are cases where the aorta is rather small and you have an interrupted aortic arch, and these are very rare. More importantly is, in many cases, but not always, the so-called truncal valve. So here we're not talking about an aortic valve overriding, and we have to say a valve that overrides. Let's see which vessel this is. But a truncal valve, usually a clue, is that it is often dysplastic, stenotic, and or regurgitant. I have actually seen quite a few trunks as prenatal with a relatively good valve, but the valve is very important. It gives you a clue that that may be a trunk rather than an aorta, and depending on how well that valve works, we have different prognosis for the baby postnatally. So this is on a transverse view. I've already labeled here as trunk, but obviously you have to work that out as you're doing the scan. And we see here how color can help as well, help in identifying the vessels. We have one vessel coming in our 3-vessel view equivalent. You can see that it bifurcates into the 2 branch pulmonary arteries. That's the descending aorta by the spine. We start from the fourth chamber, and in this view, although there is aortic overriding, it's foreshortened, and that will be better appreciated in a sagittal view, or if you have an oblique technique where you can elongate the vessel coming off the left ventricle. And further up here in the mediastinum, we see that same vessel coming here will come through the bifurcation, and then further down that trunk continues, and it comes as the aorta. And in this case, it was also a right side aortic arch, which is not infrequent if you have a common arterial trunk. This is a different patient with an arterial trunk, and you see this, the valve is slightly dysplastic, but actually had good function, and it's much easier to appreciate the overriding from this view than from a straight transverse sweep through the fetal chest. And this is again from another patient with a trunk where you can see a bit more of the large VSD here, but you also see how the leaflets of the truncal valve are slightly thickened, and as we come up we see that bifurcating and then continuing as the aorta. So if I just break that down, it's important to stop your clip so you can actually appreciate that there is a rather large ventricular septal defect, that if you're playing that very quickly without stopping, you might overlook that. As you come up, you see the leaflets of that valve slightly thickened, but also was open well, and there was no significant regurgitation. And as you come up, that vessel, which is overriding, is going to bifurcate, and there we're seeing one pulmonary artery here and just the beginning of the other. And as you come up into the mediastinum higher up, and then you can see that same vessel is going to form the aortic arch. So it's not difficult to make the diagnosis, but you have to look for the information to complete all the anatomical details. Now we've gone through an overriding aorta, which was the beginning of the title, an overriding trunk, and now the vessel could still be an overriding pulmonary artery. So if the vessel overriding is the pulmonary artery, it should bifurcate into the two branch pulmonary arteries and continue as the arterial duct. And if we do have a second vessel, that will be the aorta, and it's usually connected to the right ventricle in the most common associations. So again, if we come to the ventricular arterial connection, depending on the degree of overriding of the pulmonary artery, i.e. if it's overriding by no more than 50%, we assign that pulmonary artery to the left ventricle. So then we're talking about discordant ventricular arterial connections with a VSD and pulmonary overriding, which is transposition with a VSD. Or if that pulmonary artery arises more from the right ventricle, more than 50%, and then that becomes a double outlet right ventricle. It's just a terminology that is used to describe. So we can have transposition with VSD if the pulmonary artery is more than 50% from the left ventricle, or double outlet if it arises more from the right ventricle. And this is an example of an overriding pulmonary artery. You can judge here if it's more or less than 50%. I think it's probably just a little bit more. With an aorta, which is in an anterior position. In this case, it's smaller. It had a degree of aortic arch hypoplasia. And you also had a localized coarctation at the aortic isthmus. Here we have the ventricular septum, a large VSD, an overriding vessel, which in this case turned out to be the pulmonary artery, with an anterior aorta, the two vessels in parallel. And although in this case here we do have two good-sized ventricles, a large VSD, if we actually look very closely, that mitral valve here is straddling the ventricular septum. So it has chordae that come in here to the left side, but also go into the right ventricle. And those are details that one has to be very aware if you have double outlet with a overriding pulmonary artery and a large VSD. Abnormalities of the mitral valve are relatively common, and although this has two good-sized ventricles, it would fall, in this case, and it did fall, into a univentricular repair that Lindsay had talked about, because it was not possible in this case to close that ventricular septal defect. So there are a lot of nuances on the diagnosis that are more for the cardiologist to sort out. So I think I'd like to finish here by changing that title again, similar fashion to what Lindsay had said, and not say there is one vessel overriding, this is the aorta. Well, you have to prove that that's the aorta, because that vessel may be the pulmonary artery and may be a common arterial trunk, and the implications are quite different. And I think I'll leave it on that. Thank you very much.